Our fourth, our next speaker will be Dr. Clarence Lei Changmo. Is no need introduction. Actually, Dr. Clarence is a father of urologist in Sarawak. Need no introduction. Dr. Clarence is a consultant urologist in Norma Medical Center in Kuching, qualified from University of Malaya in 1981 and obtained his fellowship in Royal College of Surgeons and Physicians of Glasgow in 1986. Subsequently, he trained in Institute of Urology, London and Great Ormond Street Children for Sick Children, London, Edinburgh, Western GH, and Nuffield Transplantation Surgical Unit. And he obtained his FRCS Urology and FEBU. And long list of CV. Please welcome Dr. Clarence. His topic today will be BPH case-based discussion. Please, Dr.
Thank
Clarence.
you so much, Mr. Chairman, Dr. Moni. Good morning, ladies and gentlemen, and also a special good morning to those people who are not in the room. They're either outside taking tea or they're online. I was told that almost 100 people registered online. So now we have a different kind of meeting now, although there are few people in the room, but we can have a meeting that can reach out to the rest of the world. In fact, last weekend we had the Borneo Urology update, and about 1,000 doctors registered online. So we're going to have a different format of meeting. We hope to reach out to more people. So today my topic is BPH, Benign Prostatic Hyperplasia, a case-based discussion. This is a sponsored talk. And like most sponsored talks, we need to talk about the product. But I noticed that, I was discussing with my good friend Dr. Simon Wong just now at the back. We noticed that many of these talks tend to be a lot of drug information, evidence, studies, the speaker's profound knowledge of the topic. But actually, I think what is more important that we must share useful tips for the audience, people who are listening into this. So I'm quite passionate about this. I'm passionate about sharing and learning, not just telling you what I think should be the treatment. So I'm going to go through my slide, Mr. Chairman, fairly quickly. And if there are any slides you are interested, you can screenshot it, or you can email to me. I can send you my PowerPoint. And I was just told by the organizer that these talks are available online as we talk. So there's the avenue for further detailed study of the lecture. I think I will dedicate more time for a Q&A so that we learn and share from each other. So what is new about this topic of LUTS or BPH, LUTS BPH? As a urologist for more than 35 years, I can tell you that LUTS is a very important component of urological practice. And I can tell you it can be a very important component of your practice, especially for the general practitioners. Among the public, the concept about BPH is, my prostate is big, so I must do something to reduce the size. But is that true? And as practitioners, how can we prognosticate BPH? In other words, who are the people that must go on treatment? Who will get into trouble? And people like to do investigations nowadays. They go for CT scan, MRI, but in actual fact, what is the minimal test that you need to do for patients with urinary tract symptoms? Then, of course, we talk about medications. Everybody wants to have a medication. What are the different kinds of medication available to you in the place you work? What is the cost economics? And what about non-medications? Now with this COVID-19, there's a lot of interest in healthcare. What are the things that we can do to modify our lifestyle, our diet, supplements, not only for the prostate, but for a lot of things in our daily life. And then I will discuss with you my recent cases and my preferred management, which may be right, which may be wrong, and there's room for discussion. And finally, a word about Nocturia. So this is my diagram, the Clarence Lei diagram about the prostate. I have dispensed with flow charts and consensus statements. So the prostate gland to me is a sexual organ. It produces most of the semen, is responsible for ejaculation, and also important for erection. So if you have no prostate, then you won't have semen, you cannot ejaculate, and your erection will be very bad. But the prostate is only one component of this story. The other component is the bladder. Bladder is responsible for storage and voiding. And of course, these two organs must work with each other. The sphincter, that's the doorway. And of course, we have the penis, we have the testes, and of course, most important, we have the kidney. Yeah? We've got at least 2 nephrologists in the audience here. So the kidneys play a part in the whole framework of LUTS, lower urinary tract symptoms. So it's important you make a correct diagnosis so that you can give the patient the correct treatment or the advice. May not be a tablet, advice. So people think only about the prostate, but nowadays we know. Now in the last 5 years, we know that the bladder is a very important component of urinary symptoms. We used to think it's infection. So anybody comes with urinary symptoms, we give them antibiotic. But now we know may not have an infection. We used to think that the bladder may be overactive. Let's put the bladder to sleep, give them an anticholinergic. But now we know more than 50% of the patients actually have an underactive bladder. Bladder not working well. That's why they have urinary symptoms. Then of course we have the urethra, we have the sphincter, and of course the organs nearby, the rectum, the cervix, and of course the kidneys. And then all these things is controlled by nerve. The nerve in the pelvis, cancer rectum, surgery to the pelvis, the spinal cord, backache, prolapse disc, and then the brain, and of course the hormones produced by the body, which regulate all this. So we must look at the patient in the entire spectrum before we give them a tablet or give them surgery. Okay, now we go to the topic about BPH. BPH is benign prostatic hyperplasia, enlargement of the prostate caused by overgrowth of prostatic tissue. It can lead to interference with the urination. The public belief is that as the prostate enlarges, it will cause problems. But actually, it may not be so. If the prostate enlargement is on the peripheral zone, you can have a huge prostate, but you can pass urine very well. Okay? In terms of prevalence, there is a very high prevalence of BPH. I can confess that I'm 66. I think many of this in this room are also of that age group. And at this age, the chance of having BPH is 66%. So many of this in this room actually have BPH. Okay? So how common is it in your practice? You look at the patient's profile. So I can say that many of your patients have urinary symptoms. So how do we form a diagnosis from the history? How do we diagnose it? Previously, we just say prostatism. Prostatism. So patients, whatever the patient complained, prostatism, dear Dr. Lei, please do a TRP for the patient. That was my referral when I was in GHCAL 1987. But now things have changed. Now we actually quantify, we actually separate the symptoms of the urinary tract so that we come to a diagnosis. So the first group of the symptoms are the obstructive symptoms. Patients have poor stream. They have to stand for a long time in the toilet. The stream may be intermittent. There's terminal dribbling, okay, and there's post-void dribbling. Then the other group of symptoms are the irritative symptoms or the storage symptoms. So patients have frequency, nocturia, urgency, urge incontinence. And if the patient does have BPH, they should have no pain, they should have no blood in the urine. Okay? So you may be wondering why I put this picture here. This picture is my daughter. She is now a physician in London. In 2015, she listened to one of my talks, and she told me, as a medical student, that's how she remembered her urinary symptoms. PhD stands for obstructive symptoms. Okay? Poor flow, hesitancy, dribbling. And then funny stands for another group of symptoms. These are the irritative or the overactive bladder. Frequency, urgency, nocturia, incontinence. But bear in mind, these symptoms are not specific to the prostate. So the woman don't have a prostate, but they can also have these symptoms. Another important piece of document which some people don't use, actually I didn't use it for the first 20 years of my practice as a urologist, but now I use it every day. This is called the IPSS, International Prostate Symptom Score. So with this, you can quantify the symptoms. We can do comparative studies between different countries. But the most important question in my mind is the quality of life. Quality of life. So a lot of patients in Asia or in Sarawak, they have a lot of symptoms. They got post flow, they got urgency, they got frequency, they got nocturia. But you ask them, how long have you had this? Oh, I have this for 10 years already. I'm not so concerned. It's just like me, you know, I drive my car slowly, my old car, 20 years car, I drive it slowly. It doesn't bother me. Okay, so the symptoms may not tally with the outcome of the patient's condition. The commonest symptom is still nocturia. Nocturia, okay? So if you have nocturia, of course, it can affect your sleep. And if you have polyuria, nocturnal polyuria, in other words, you not only pass urine very often at night, but you pass a lot of urine at night, that can also affect many conditions. We can discuss that later on. Women also have a lot of nocturia, but they have no prostate. Next, we go to examination. A lot of doctors actually don't examine the patient. They don't even look at the patient. They just give the patient some medication. I think examination is very important. First of all, you have to inspect the penis. This diagram, this picture is taken a long, long time ago. There's my fingers, okay? So if I show this to a group of medical students, I'll be doing them a big disfavor because I'm not wearing gloves. So the patient can complain against me. This is the rectal examination. Again, if you are the only doctor seeing the patient, you're not referring the patient, you're going to give the patient medications for months and months, you must do a rectal examination. Okay, we have reduced our message to doctors regarding and the medical students regarding rectal examination. If you're going to refer the patient, you don't need to do rectal examination because we don't want the patient to have too many rectals done because it's not a very pleasant experience for most people. Okay, so that is the next thing is the urine test. I think that every clinic should have the ability to do a urine test, dipstick, and preferably to print out the urine test. And I think in Malaysia, we should do a blood sugar test, check the blood pressure and the body weight. I think this is the minimum for every clinician seeing patient. I'm actually amazed that even in this day and age, I've got patients who have been to many, many, many clinics, and they come and see me, and because I'm going to give them medication which can affect the blood pressure, they haven't had the blood pressure taken. They have not had the blood pressure taken by many doctors. And of course, many patients nowadays, they have a blood test done. And the blood test, the important component for urology is the PSA, prostate-specific antigen. If it's more than 1.5, that means the prostate is enlarged to above 40 grams. Okay, in my mind, there's no need for endoscopy, no need for cystoscopy. I think far too many endoscopies and various tests are done for our patients. Ultrasound is very useful. I know that many of you in this room, many of you who are looking online, will have an ultrasound in your room. And to me, it's an extension of the physical examination. So if you see hydronephrosis, something is wrong. You need to investigate further. If you see a big bladder stone, of course, this stone has to be removed. No point giving the patient medications for years and years. And of course, it will give you an idea about the underlying diagnosis. If the bladder wall thickened, is retrobaculated, is the prostate enlarged, if the prostate obstructing the blood outlet, and also you can measure the prostate volume. So an ultrasound of the urinary tract, I believe, can be done by any practitioner. In fact, you don't have to be a practitioner. Most of the time nowadays, in fact, if you go to any of the private hospitals, the ultrasound is actually done by a sonographer. So as far as urological imaging is concerned, the most important imaging is the ultrasound. But in some places where you don't have proper ultrasound or you have no training in ultrasound, then the X-ray is important. I think many hospitals in Sarawak, in the rural areas, you can easily do a KUB. And I think stones are still very important. And stones are an important cause of urinary symptoms. The next investigation, which is like a must-do for most urological conditions, is non-contrast CT urography. And this is not any CT scan. It's the low dose and it's the stone protocol. In other words, the patient is not exposed to a lot of radiation. And if there's hematuria, then we give contrast to the patient. We try to avoid CT scans in children and in young females. I see a lot of young females admitted to hospital with abdominal pain. They get up-down scope. They get the contrast CT abdo-pelvis. I think that's really overkill. Not only overkill, you are doing damage to the patient. I want to mention a word about uroflowmetry. Uroflowmetry. I consider uroflow a must for all urological clinics. Just imagine you are a cardiologist. You're treating a patient for high blood pressure for years and years, and you never measure the blood pressure. So I think a uroflow is very important. So if this patient has got a good uroflow, then there's no indication to give the patient a medication to shrink the prostate. So this is obviously obstructed. And if you give the patient medication, after 6 months or 3 months, uroflow is good, then your medication is effective. And I'm not saying that uroflow should be restricted to just urologists. You go to the UK, the gynecologists do it, the family physician do it, and the GP, some of them, if they have an interest in urology, they have a uroflow machine. It's just like doing an ECG. You can send the patient to the urology clinic for uroflow without the patient seeing a urologist. Now we talk about medication. what the patient wants is a medication to shrink the prostate gland. And the good news is that there are only two medications, unlike the previous two lectures which I set in just now. We only have two medications. One is finasteride. It has been here since 1990. You go into the blue book when I was still in GHKL, 1990. Finasteride, now it's available in the generic form. The other one is Avodat. They have no generic yet. So only two medications are available to shrink the prostate. Very easy for you to remember. But unfortunately, you need 6 months to show a significant effect. And if you stop it, the prostate will grow back. So you need to be on maintenance dosage for a long, long time. And nowadays, most of the medications, they put into their drug insert, which is available on the internet. What are all the reported side effects? May not be the real side effect. All the reported side effects during the trial and also in the post-marketing. And if you look at these drugs, I got so many patients who tell me, oh, now I got ED because I've taken 1 tablet of this. Or now my grandfather has got prostate cancer because he has taken this medication. And now they put a few more side effects like suicide, you know. So drugs are not without side effects. Okay? And of course you have to know about side effects because the patients will go to the internet and read, oh, this drug causes constipation. They say, oh, I've never seen constipation. But you look at it, in the internet, the drug insert, constipation from Avodat is the second commonest side effect. So don't show your ignorance by saying that it's not there. You say, okay, you think they got side effect of a rash? Never mind. Give me the leaflet and I'll look through it again. So it's often a balance of the side effects and the efficacy of the drug. I think a better drug for immediate effect would be to relax the smooth muscle of the bladder neck and the prostate. And the patient can pass urine soon thereafter. So I'm talking about alpha blockers. Alpha blockers, you give them, it works within hours and days. Okay, so a good drug to give to a patient with slow urination from the prostate is give them an alpha blocker. We can give them a 5-alpha reductase inhibitor later on to shrink the prostate gland. Okay, so but the patient wants immediate relief. They also want the prostate to be smaller, but that is not feasible unless you give them a combination drug. But combination drug, of course, there's the side effects as well. Next, I will show you a few cases, maybe 5 or 6 cases of what I see in my daily practice. So the first index case is a patient, the wife complained. The patient usually don't complain. The wife complained that he spends a long time in the toilet. Presumably he's passing urine. I don't know what he's doing there. Why does it take so long? Or sometimes when they go for a holiday to China, when the tour starts, said, the tour bus have left already. Now you are still in the toilet. So there are a lot of problems with this slow urination. So what would you do as the doctor in charge of the patient? Give them alpha blocker. The commonest alpha blocker in use actually is prazosin. 1 milligram, half at night. I see a lot of doctors from the smaller towns like Serike, Pintango, they give this prazosin. Or even the clinic kesihatan in say Belaga, they give prazosin. Or some doctors will give terazosin, 2 milligrams. Then now some of the younger doctors who have a lot of these sales girls visit them and say, oh, you better start them on dose therapy, give them early. A lot of drugs nowadays, the companies are telling you, you must give the drugs early to have a maximum effect, you prolong their life, improve the quality of life, blah, blah, blah. Give them early Duodat. Duodat is a combination of Avodat and tamsulosin. And also, you don't have to think, right? You give them one shot, both medication. That's like the cardiac patient, give them for hypertension, for cholesterol, just give them some combo drug. Or, no, I don't give you medicine, let's do blood test first. Do the urine test, blood test, the PSA. Or never mind, you can do an ultrasound first, then you come back. So these are the options you can do. So I will discuss with you each option. I will not give them prazosin. Okay, why? Because prazosin is actually used for hypertension. I used prazosin in 1986 when I was still in GHKL. At that time, Pfizer comes out with actually a starter package. Because prazosin to be effective for the prostate have to be 2 milligrams BD. If you give an old man 2 milligrams BD, he will have postural hypertension. He will faint, So we can't give them 2 milligrams BD. So if you give them prazosin for whatever reason, you have to titrate it. Like in the public clinic kesihatan in Belaga, then you have to start slowly. I also won't give them terazosin 2 milligrams at night because that is also not so uroselective. They can also have postural hypertension, and also we may not work. You cannot give them 5 milligrams or 10 milligrams upfront. They will have hypotension. So I will give them a uroselective drug, which have minimal effect on the blood pressure, so I can give them the maximum dose immediately, and I give them maybe for just 1 week. If you talk about cost concern, you know. Examples, okay, for today is Urif. So I will give them a uroselective maximum dose alpha blocker for 1 week and see whether it works. Okay? If it works, then the patient will be so happy with you, and then you can discuss about, you know, de-escalate, you know, or change to another drug. I will also not give them Duodat, because all these drugs are very expensive. I think about $10 per tablet. And we know that to shrink the prostate, it takes time to work. So if they need an alpha blocker, I'll just give them an alpha blocker. Now, the comment about blood tests in Malaysia, especially in Sarawak, is that patients would have done the blood test already. They would have done their PSA, they have done the blood glucose, they have done the urine test. By the time they come in, well, most of them, if they haven't done, I think it's not unreasonable, but before that, you better do digital rectal first, because in case the patient has got a prostate cancer. Ultrasound is optional. To me, if the urine test is normal, if you have the ultrasound machine, of course you use it, because it's part of your physical examination. Patients often go to the hospital for a wellness checkup. Remember that wellness do not include ultrasound of the bladder and the prostate. Do not. Okay, patient, I've done the ultrasound in this medical center, it's all normal. But the patient may in fact be having a bladder cancer, or maybe in fact having a big bladder stone. Okay, so remember that ultrasound of the abdomen does not include the pelvis and the prostate. Okay, case number 2. This patient is youngish, 50 is very young, very young. Got troublesome frequency. When they attend meeting, you see them running out. When they attend my lecture in Unimas, they will run out to the toilet. And if you are in KL, you're working, well, not only KL, I think Kuching also having the same problem. You keep plastic bags in your car. And if you have to attend long meetings like the High Court judge, he has to wear urinary diapers. I don't know if you are a matron or a sister in the ward. I don't know how, because anyway, I think there are probably toilets there. Okay? And sometimes it's associated with urgency. Okay? Urgency. That means you have to run to the toilet, and otherwise you will leak some urine. Okay, there's myself. This is the pair of pants I'm wearing. Exactly same pair of pants, same shirt I'm wearing. Now I have to change some of my slides, because if I show a slide from the internet, I get problem when the thing is listed on YouTube. So this is actually myself. I'm the actor here. So you may have to wear dark pants. You may have to wear a skirt. I show you another case. Now, you know, in Sarawak, we have a lot of this clinic Kasiatan. Last time we have one Malaysia clinic. So I show you a case which I pick up. But the good thing is that in Sarawak, the patients have a home-based card. So actually the doctor write down everything. So this doctor in one of the bigger towns, see our classical patient, diabetic hypertensive dyslipidemia, complaining of urinary symptoms for 1 year. 1 year, I don't know why, 1 year, okay? The urine stream is good, no weak stream, but he has frequency, urgency, nocturia. Quality of life, 3. 3 means neither here nor there. 1 and 2 is good, 4 and 5 is bad. So 3 is neither here nor there, so he has been tolerating for 1 year. And this doctor even do a blood sugar, and not only blood sugar, HbA1c as well. I think they have done too many HbA1cs. And they did a rectal examination, prostate enlarged. But unfortunately for the doctor discussed with a person called FMS. I just found out that FMS is a family medical specialist, something like that. And instead of giving treatment for the bladder, the patient was given terazosin 1 milligram for 1 week. 1 week or 2 weeks. So actually, the patient doesn't have BP, or the patient has got an overactive bladder. So this is another misdiagnosis. So if you take a proper history, a focus history, focus examination, you came to the wrong conclusion. So that is what my sharing with you. Another case I share with you, 74-year-old plumber. So his complaint is leg swelling and nocturia for 6 months. He has gone to KK because he has to look after the grandchildren. As we grow older, that's one of our main purposes in life. And he saw the GP. The GP said, leg swelling, give Lasix. But of course, if you give Lasix, especially if you take it at night, the nocturia will be worse. He said, no, never mind. think now we better go to the clinic Kesihatan. The doctors there are young, they're energetic. So of course, this doctor, he has attended a lot of urology lectures. Oh, Nocturia, must be the prostate. Okay, give mini press, 1 milligram BD. Of course, he didn't get better. So he came back to Miri, and I got permission from this senior physician. You know, there are not many senior physicians in private in Miri, Dr. Chong Hoi Hee. So Chong Hoi Hee was his family doctor last time. Run a blood profile on him. And I think everybody in the audience will know this patient has got prostate cancer. Prostate cancer, not only prostate cancer, he has gone to the bones, the lymph node. So this is the wrong diagnosis. And this is still happening. This is 2017. I'm sure it will continue to happen, whatever we say. So maybe our lectures not so effective. Another wrong diagnosis. This is one of the big towns in Sarawak. Okay? So I went there, and then this patient came and see me. Hey, doctor, I said, I have been taking this medicine, dual therapy. In fact, there's only one dual therapy in urology, duodat. And it's available in the Ministry of Health for 5 years. And this doctor, very conscientious, he sent me to the Euroflow clinic 10 times already. But my flow has not improved. Why? So I said, what has happened to you? Oh, any surgery done before? I got surgery done on my knee. Yeah, I tell you, a lot of people got surgery done on the knee nowadays in Sarawak. I said, surgery on the knee should not affect your urination. Oh, no, after the operation, I got bleeding from my penis. I said, why? Oh, they tried to put a tube into my urethra. And they said, oh, I said, that must be the problem. So they gave me a clue. So I sent him for a urethrogram. It means inject contrast through the urethra. And he got a stricture there. So stricture is still there in Malaysia. Younger people is from iatrogenic. Older people is from previous STD. STD. Now STD don't cause urethral stricture anymore. STD do not cause urethral stricture anymore nowadays. Another case, the wife complained. Usually it's the wife who complains about the husband. The husband not much complain. So he said, this guy, he's waiting in the bed at night. What happened to him? And if he go out, we have to put him on Pampers. Okay, so remember this condition. Recent onset nocturnal enuresis. Any of your patients with recent onset nocturnal enuresis, there's only one diagnosis, high pressure chronic retention. You lie them down to examine them, the bladder is obviously palpable, almost like a pregnant lady. And if you put a scanner on them, they got biliary hydronephrosis, you send the blood profile, they got raised creatinine. And the blood pressure usually on the high side. So you treat this one, all this will resolve. If you don't treat it, they go into kidney failure. Another case, this patient was treated in a top medical center. There are many top medical centers nowadays. So had phimosis, circumcision done. Had the cystoscopy done. Then after that, I have a TLP done. After that, still cannot pee. Okay, cannot pee, never mind. Long term, the urologists now say this, don't put the urethral catheter, put the suprapubic catheter. Wait for another 3 months. Still cannot pee. So actually this patient, you look at it, even the big toe has to be chopped off. The patient has got diabetic neuropathy, giving rise to an underactive bladder. So no amount of surgery will make him pass urine. So if you study them carefully, this is the normal urodynamics. When you pass urine, this is the uroflow, the bladder contracts. These people, the bladder do not contract. They cannot contract. So that's why they cannot pass urine. These patients, the bladder muscle contract a lot, but they still cannot pass urine. So this is an obstructed bladder. This is an underactive bladder. So what are the causes of underactive bladder, which is very common nowadays? It's the new condition that is recognized more and more now, maybe the last 5 years. So there are many conditions nowadays which give rise to an underactive bladder. Neurological condition. We got a lot of stroke, we got dementia, we got spinal cord problems, backache problems, prolapse. We also got peripheral nerve problems, especially from diabetes, from many medications. And in fact, the bladder muscle, as we grow older, the bladder muscle itself can undergo failure, gross distension. People sitting in the room the whole day. I see Mr. Chairman sitting there the whole morning. He doesn't go and pass urine. So his bladder is over-distended. Then you get bladder fibrosis. Then, of course, sometimes the scientists say, oh, maybe the mitochondria in older people don't function so well. So remember this condition called underactive bladder. Doing an operation will not get them to pass urine. Okay? Okay, one last case. This is very recent, 24th of May. So this patient came into my room. Doctor, I cannot sleep at night. I have nocturia. I pass urine a lot. I pass urine very frequently. But after each time I pee, I hydrate myself. Hydration, very important. The doctor said hydration. They must drink a lot of water, otherwise their brain will string, you know, or the penis will string. So they think hydration very important. But what actually woke him up is that the wife have to go and look after the grandchildren. But every night the wife will call up at midnight or past midnight. And not only they call up, the wife said, you must video call. You must be a video call. Basically the wife is checking on him, you know. So there are so many reasons why as we grow older, we don't have good sleep. And then he said, my wife must have the aircon. I said, don't on the aircon. On the aircon is, you know, the temperature drops. When the temperature drops, you got diuresis. He said, no, my wife must have the aircon. So I said, in that case, this is an excuse. Sleep in a different place. Okay? So then another thing, of course, nowadays we got, even in Kuching, we got dogs, we got birds, we got garbage tract. The garbage tract will come at 4:30 in the morning. So all these things give problems to nocturia. So we can discuss that another day. So no point giving a tablet. No point giving these patients a tablet to stop the urination at night. No point giving them some tablet to improve the urination at night. Okay, now this is the commercial part. Why am I asked to talk about this topic? Why am I paid some money? I actually haven't got the money. So to give this talk. That's because I'm one of the big users of silodosin in Malaysia. And I have got a lot of corporate clients. So I analyzed them about 2 years ago. I got 100 over patients. Why is this girl here? Oh, females also can have upper blockers. Usually it's for lower uteric stone. Usually most time we don't use it for bladder outlet obstruction for females. So this girl is on not this girl, just put a picture there to make you wake up. So these girls take alpha blockers because they have lower uteric stones. What are the age group of my group of patients which I analyzed 2 years ago? Most of them are 60 to 80 years old. So mostly elderly people who have problem passing urine, I give them this alpha blocker. Older people, usually they may have to go a lower dosage. The drug leaflet say you take it twice a day, but quite often I give it once a day. I haven't used it in children, so because some children also have got voiding problems. So most of my patients who is on this so-called new drug, silodosin, are mostly new patients. Some patients, they were previously on an alpha blocker. I think many of you in the audience have experience with alpha blockers, tamsulosin, doxazosin, prazosin, you know. Sometimes they're not happy, so I can try them on a newer alpha blocker, and sometimes it works. The side effects are very similar, but sometimes if we change to a different alpha blocker, the side effect of nasal stuffiness and low blood pressure may not be there. And I use it also in a few dyssynergic coitus. We just try on these patients who, for some reason, young people who cannot pass urine well. What is the advantage of this medication? This medication is super selective for alpha blockers in the bladder neck and the trigone. So compared to all the other drugs that you may be used to, especially tamsulosin. And this drug is efficacious within 2 hours. This is quite important to us as clinicians because if the patient comes to see you with difficulty passing urine, the reflex action is to put a catheter or send the patient to the hospital to put a catheter. But if the patient doesn't want a catheter, and I can tell you almost everybody doesn't want a catheter, you can give them the medication, keep them in the clinic until you close. Say if you clinic close at 4:30, you say, okay, you stay here, don't drink anymore, you sit here, we take this medication and see whether you can pee or not. If by 4 o'clock you haven't pee, either I put a catheter or I send you to the nearest hospital to be catheterized. Another way to use these alpha blockers, especially the highly efficacious uroselective alpha blockers, is for the trial of catheter. I see so many patients over the years, and it's still happening now. Patient go to the emergency department or go and see a doctor, they put a catheter, and they put there, go to the nearest doctor, the nearest clinic kesihatan, to have a trial of catheter. But the patient is not giving any medication at all. So it doesn't make sense, right? So to have a successful trial of catheter, the patient must be given some medication. So you can give them an alpha blocker. So if you give an alpha blocker, the chance of success is much higher, 76.7%. If you don't give them medication, many of them can still pass urine because maybe that day they have constipation, they have a flu, the bladder over distended, they went to a party, they drank too much alcohol, but some of them can still pass urine, even if you don't give the medication. But it's much better to give the medication so that they have a successful trial of catheter. Some more commercial about the medication. So silodosin is actually not exactly just like Panadol. It actually works to reduce the pressure in the bladder if you give them alpha blocker. And I think this, generally speaking, is true for most of the alpha blockers. They do reduce the chance of the bladder being over distended and the bladder subjected to higher pressures. What about the problem of hypotension? If you give the patient the medication, he goes back, he takes it, then he goes to the supermarket and go to all these escalators and he fall down. Big trouble, right? Big trouble. The doctor will call you up. My father fell down here. I go to the hospital, have to do a CT scan, they have to stitch him up. How come you give my father this medication? So whenever you give a patient a medication, try to warn them of the significant side effects. Although this is very rare, it's maybe about 1%, but you still have to tell them. You still have to tell them that you have to take it at night. Taking at night in Kuching means you take it and stay at home. Because a lot of people take it at night and go to after makan, they go and jalan-jalan, you know. So you take it at night and stay at home. And then when you get up to pass urine in the middle of the night, don't certainly sit up and go to the toilet. In fact, better still, you just sit up and pass urine to a urinal near the bed. Some more side effects. I think there has been quite a few of our colleagues who passed away recently and suddenly passed away, you know. So maybe there's something wrong with the rhythm. So a lot of these drugs, if it affects the cardiac rhythm, especially if you have got this condition called QTC abnormality, then if you take the medication, it can somehow affect your cardiac rhythm and you may have suffer from a sudden death, especially if you have underlying heart problem. And this drug has no side effect, no effect on the ECG parameters. What about taking with other drugs? You know, when you reach 60 or 70, you often have poorer erectile function. Not impotence, just poorer erectile function. So you may want to take something to improve the erectile function. And that something may also affect the blood pressure. So if you take an alpha blocker to improve the urine flow, you take a PDE5 inhibitor to improve the erection. Then you take another medicine for your blood pressure. You take another medicine for your cholesterol. There's so many drugs together. But luckily, this particular drug do not clinically affect your blood pressure if you take it with tadalafil. Okay, tadalafil 5 milligrams is very popular now in the world. So actually, the discontinuation of this medication is not high. The most frequent cause for the discontinuation is ejaculatory problem. Last time they say retrograde ejaculation. So this man, he takes it and he finds that he has got very much less ejaculate. The girl thinks that he has done it somewhere else. Or why is he so clean nowadays, you know? What happened to him? Or he thinks that maybe the semen has gone somewhere else. So this is a problem for some patients. And some patients, maybe they feel not nice, bosong, they don't feel nice after sex. You know, they have this retrograde ejaculation. All the rest are not so common. Like orthostatic hypotension, only 0.2%. So we need to spend some time talking about ejaculation if we want to talk about this product. So actually it's not retrograde ejaculation. Basically there is reduced ejaculation. And if you do not suffer from this side effect, it seems that actually the drug is not effective. So a lot of drugs nowadays you take for all kinds of conditions. Like for prostate cancer, you take it, you got skin rash. And they say if you don't have a skin rash, that means the drug is not effective. So this apparently is the indicator that the drug is effective if you have retrograde ejaculation. Now, this retrograde ejaculation thing, does it really affect men very badly? This is reversible. This is reversible on discontinuation. And if you reassure the patient that actually it should not affect orgasm. And as far as the female is concerned, it doesn't really matter whether the man ejaculate or don't ejaculate. Okay, for most women. Okay, that one we have to discuss another day, another time. So this is the ejaculating problem which you have to tell the patient. Otherwise, the fellow will call you at 2 o'clock in the morning. How come? What happened to my semen? Should I go and see a doctor now in A&E day? So you have to tell them, you have to take it at night. and go to sleep after that or go and lie down. And you may have less ejaculation, especially if they're younger people. I tell them, less ejaculation. Don't say no ejaculation. No ejaculation, then big trouble because the girlfriend may get pregnant. Okay, so less ejaculation. It also helps to reduce nocturia. These alpha blockers, especially silodosin. And if you are already on an alpha blocker and they cannot afford it, or maybe they got side effects, you can switch on to this alpha blocker and it seems to be effective. So that's all the commercial, no more commercial already. So, but of course patients want to have the pill. Patients want to have the pill. I'm not sure where I got this slide. Maybe it's from Dr. Liu, maybe in the private doctors chat group. So people somehow, they like to have a tablet. They don't have a scan. They don't have an MRI. Lifestyle changes, many patients, when they see a doctor, they are not so keen. But I can tell you lifestyle changes is one of the most important things that eventually the patient will want to know. So if you have frequency, urgency, nocturia, it makes sense that you should drink less. So I'm giving this lecture now. So this morning, I didn't drink a lot. During tea time, I didn't take my tea just now because I also have OAB, overactive bladder. And then as we grow older, or as we are very busy people, busy professionals, and then matrons, sisters, sometimes the bladder will not tell you the bladder is full. So you must practice what is called time voiding. For people with LUTS, you must practice time voiding. In other words, you empty the bladder regularly every 2 hourly. If you are flying, take the aisle seat or upgrade to a business class. And in UK, my daughter tells me that there are not so many toilets, unlike in Malaysia. Everywhere coffee shop got toilets, although the toilet may not be that conducive. So Mark and Spencer in London have toilets. And if you are caught in a traffic jam, you have to wear Pampers. It means you have to put plastic bags or wear Pampers. And for elderly people, sometimes they cannot tolerate the medication, or there are many other comorbidities, or they don't take medication. Then if you have to attend an important function like your granddaughter's wedding, by all means just wear Pampers. So lifestyle modification is very important. And you don't have to take a medication for OAB and for alpha blockers for life. Those medications to shrink the prostate, of course, you have to take it for long term. You can take it as required. So you bring a medication when you're going on a journey. And more than just the fluid, the diet is very important. If you take a lot of sugar, if you take the medicine, just not the endocrinologist recommended, you got a lot of sugar in the urine. Of course, you got frequency. Of course, you get urgency. If you take salt, you could go to have a nice dinner, take salt, you take a lot of food, take a lot of carbohydrate. Of course, you will have nocturia that night. So it's quite important to modify your lifestyle and your diet to suit your urinary symptoms. And I think that goes for almost all the diseases. And this bladder care concept, again, my daughter, I must give tribute to my daughter, because in London there are a lot of elderly people walking around here and there. So there's this idea called bladder care. That means you look after your bladder, not only the skin, look after your bladder. Empty the bladder well before you go out. If you're going for a long time, take the medication. You may have to wear Pampers, and also look after all the other medical conditions. Sometimes you may have to double empty. You're going for holiday. There's a group of young people. They are restless. They want to run here and there. The bus is going to leave. So you quietly go and empty your bladder, double empty your bladder before you go on the journey. So all these bladder care, lifestyle changes are very important. All these things are probably intuitive. But I can tell you for every condition, there will be a study done. And many of these studies actually now come from Asia. This is a Korean study done on 70,000 men. And they look at these men and analyze many parameters of their symptoms. And one of them they analyze is the bladder symptoms. And they find that if you exercise, you've got much less bladder symptoms. Okay, I'm coming to my last few slides. So my take-home message is, which drug do you use for patients with BPH-related LUTS? I will start with an alpha blocker for 1 or 2 weeks. And if it works, then it's okay, your prostate is enlarged. How to know the prostate is enlarged? By the rectal, by ultrasound, or by doing a PSA. Then I add on another drug, like dutasteride or finasteride, telling them the side effects. If the patient says, doctor, I don't want to come and see you every week. You just give me a medicine for 3 months. That's like many of the Indonesian patients, So if the prostate is enlarged, the slow uroflow, I will give them a alpha blocker plus a 5-hour reductase all the time. Then many of our Malaysian patients, especially our South African patients, especially patients from Cebu, they say, I got no more money, no money. So you can downgrade to a cheaper alpha blocker or make arrangement for them to collect from the government hospital. Some patients cannot tolerate the alpha blocker. They got low blood pressure, like my father, low pressure all the time, 90 only, but they're okay. So those patients cannot take alpha blocker, we give them a 5-alpha reductase inhibitor straight away. After you have taken the 5-alpha reductase inhibitor for 6 months, the prostate is smaller. Then you can stop the alpha blocker, so that you got less side effects and less chemicals for the patient. If the patient still have bothersome symptoms from overactive bladder, you can give them a medication to relax the prostate. And the favorite medication is mirabagrone. So it's for you to choose your medication. And just to summarize, don't forget all these important health tips, exercise, good sleep, and of course you have to monitor the vital parameters, other parameters. Surgery is only in a very, very small number of patients, in my view. Who are the patients who go for surgery? When they have obstructive uropathy, when they have stones, when they have recurrent UTIs. Then, to me, the gold standard is still the TRP. Okay, although there are so many things in the market, water vapor, laser, frequency, cryosurgery, spring, the dilatation, all kinds of things. But to me, I think it's still the TRP. And very few patients require surgery. And in fact, many patients do not progress. 52% are stable. Only 16% will deteriorate. So you have to pick up this 16% and start them on early therapy, early medical therapy. So this is my last slide, my summary slide. So alpha blockers are useful for BPH-related symptoms. It's good to start off with efficacious medication, for example, silodosin. You can add a drug to shrink the prostate later on. If the patient still have symptoms, it may be due to the bladder, then you can give them a medication for the bladder. Remember to manage them for their comorbidities. I still get patients coming to see me, blood sugar is 20. They got frequency. So you control your blood sugar first, then we see how. And lifestyle and nocturia concerns. I said earlier when I started, I want to leave time for Q&A because that's the only way we can learn from each other. Thank you for your attention.
Thank you, Dr. Clarence. Any question from the floor?
Gastroenterologist.
Clarence, thank you very much for the very good lecture. Can I ask, if a patient has no prostatic symptoms, but was found to have slightly raised PSA on blood tests and ultrasound show enlarged prostate, but no evidence of prostatic CA, is there any reason the patients will be started on alpha blockers? Does it reduce their risk of getting prostatic cancer in the future?
Answer is no, zero. If the patient has got a good urine flow, there is no grounds at all to give them any medication. People still do that, oh, I want to take this medication to shrink my prostate, but later on, after 2 months, they look at the leaflet, my God, so many side effects, I better stop it. So there's no reason to treat the prostate enlargement or the raised PSA, but especially the prostate enlargement. PSA is a different story. So now I come back very briefly to the PSA story. Virtually nobody, no health authority in the world recommends PSA screening for prostate cancer. Virtually none. Because the harms of doing the PSA. First, the patient get worried. 2, you need to confirm the prostate cancer, you need to do further tests like a prostate biopsy. That can cause bleeding, infection, death. Then once you diagnose the prostate cancer, you feel obliged to remove the prostate. That causes a lot of sexual problems. Not only that, 5% are permanently incontinent. Of course, the cost of doing the PSA screening, the biopsy, the MRI, the CT scan, the PET scan, is a lot of money. So virtually nobody in the world recommends routine PSA testing for prostate cancer. But having said that, we have these patients in front of us. I got the raised PSA, 5. What should I do? So the health authorities have a risk stratification. Look at the risk. If they got family history of cancer, especially breast cancer, prostate cancer, pancreas cancer, ovarian cancer, and especially young prostate cancer who die. So the sister got breast cancer at 40 and died. the father got prostate cancer at 60 and died. So if they have a high risk from the family history, then we will further risk stratify them. Nowadays, we do a multi-parametric MRI of the prostate. So then we grade it just like the breast, no? Pyrex 1, 2, 3, 4, 5. So if it seems to be a high grade, then the patient will be subject to a biopsy. Then the biopsy also we look at the grade, whether it's high grade. If it's high grade, then we remove the prostate. So it's quite a little bit of involvement, but these are available in the government hospital.
Okay, thank you.
So the PSA story is one whole lecture, a bit tough one. So don't do the PSA for the patients unless there's a reason to do it. Now, of course, if they have symptoms, of course you do the PSA. If you've got a family history of cancer, you do a PSA.
Dr. Clarence, what is the role of tadalafil in BPH?
Tadalafil is now, for a long time already, is registered for the treatment of BPH. So you take tadalafil, you will pass urine better, but the prostate doesn't get smaller. The skeptics will say that, of course, you know, everybody knows tadalafil is like sildenafil. It's good for erection. So people say you got a good erection, you feel better, so you pass urine better. So I think for younger people who got both problems, erectile dysfunction and poor urine flow, I think tadalafil will be a very good treatment. But it's 5 milligrams, 5 milligrams taken every day. And now it's available as a generic. Generic maybe about, I think, $2-3. I think it's you cannot get anything now, right? You cannot even get Laksa for $2-3. So I think it's affordable. But it's not available in the Ministry of Health. But because it's licensed for BPH, you can prescribe it on a corporate account or on an insurance account. But it's for, you must put indication BPH.
Any other question?
You can still ask me on online or WhatsApp or email. I mean, I believe in continuing discussion about, I think it's a very important topic.
There's another question on online. How frequent do we need to monitor for PSA in patients with BPH with or without treatment?
I think if the patient has got BPH, you give them treatment probably maybe 6 months or once a year. And if you give the patient medication to shrink the prostate and the PSA doesn't come down, it should come down by half after 6 months. If it doesn't come down, then you worry about prostate cancer. So the short answer is you must monitor the PSA if you are giving patient 5-alpha reductase inhibitor, at least once a year. Once a year. But most patients will do it themselves anyway every few months, you know. So the PSA is a good indicator for monitoring progress of treatment and for monitoring prostate cancer. If you remove the prostate, the PSA should be zero. If you have successfully removed all the cancer from the patient.
Okay, one last question. When do you refer patient for prostate biopsy?
Prostate biopsy, if there's a suspicion of cancer. So if I were you, if I'm a non-urologist, if the patient has got PSA of abnormal or more than 4, you should refer the patient to either urologist or to the SOPD if there's no urologist to consider biopsy. Because if you don't make the diagnosis subsequently in 10 years' time, if the patient got metastatic disease, then you can be in trouble. Unless it's a very obvious cause, like prostatitis, or after cystoscopy, or after vigorous prostatic massage. Otherwise, if the patient got a high PSA, I think you should refer the patient. Whether the patient go to see the doctor or not is a different story. You should write down there, there's a risk of cancer. Patient has been counseled to go and see a specialist to consider prostate biopsy. But of course, when they arrive at our doorstep, then we give them another counseling, the risk of prostate biopsy, and nowadays, most of the time, if we have an MRI, we do MRI before the biopsy to stratify the risk and also to target the biopsy, because the MRI will show you which part of the prostate is abnormal, so that we can target the prostate biopsy to the abnormal part of the prostate gland. Okay, thank you.
Okay, so join me for thanking Dr. Clarence for the marvelous, wonderful lecture. And I would like to invite Dr. Liu to
Thank you so much.
to present a certificate of appreciation.